What's up, guys? Dr. Nicole Coleman here. I've had some really awesome input from a lot of people about what I know, what I don't know, and I think I know something, but I want to know more, and what if I find something out and I don't know what else to do, all in regards to pelvic floor, poop, pee, and sex with their patients. And all of this discussion has brought me to the realization of the number one mistake I made as a clinical pelvic floor physical therapist. And I wanted to share it with you quickly before I go out for my morning run. And I have a little puppy here with an ear infection, so you might hear some head shaking going on. So what is it? What's the number one mistake I made as a pelvic floor physical therapist, as a clinician? I failed to educate my fellow colleagues and people in my profession about what I did and about their role in the pelvic floor, in screening, in treating, in referring, in telling them what questions they could ask, in educating them on simple external screening assessments, and educating them on how orthopedic and neurological conditions can impact not only pelvic floor, but also their poop, pee, and sex functions. I fell short in so many ways because pelvic floor is kind of like, what do? We don't know. They go into a room, they use lube, and they use gloves. And if my patient mentions anything that might even sound awkward, I'm going to refer my patient to them if I work with someone. If not, I'm just going to kind of skim over it and say, oh, there are people who do that. And it's because me, as a pelvic floor physical therapist, failed to talk about it to even my colleagues as to what it is, what they can do to feel more comfortable talking about it. Because the fact of the matter is 80% of people at some point in their life are going to experience some form of pelvic floor dysfunction. It's not that I'm sitting here with the pelvic PT hat that, like this is the end all be all. It's just that so many people experience suffer in some way from pelvic floor dysfunction. And the matter of the fact that pelvic floor aligns with so many other things. And as a profession as a whole, we failed to integrate it into the necessary components. And the further I get away from that clinical aspect, the more I realized the mistake that I made was that I failed to take the time to educate people. And that's why I created the ebook, the 7 questions to ask your patients about pelvic floor, because I had a colleague, Patty Connors, who one of the best clinicians in the world, one of the most compassionate, highly educated, trained people I know, kept asking, what questions should I ask my patients? What else should we be considering? And I was so consumed with my own stress of everything that I couldn't even answer that simple question. And someone who knew they wanted the questions. So if she knew that she wanted those questions and I couldn't provide them, what about the rest of the profession? All of those people who had heard of it, maybe they knew that they kind of knew something and they didn't know something, and that physical therapy might be a solution, but how and where do I end and where does that service begin? We tend to think of it as like completely separate. I don't even know. I can't think of anything good today, but just completely delineated. This is what I do. This is what you do. There's no crosshairs, there's no transition point, there's no linkage. And my colleague Carrie, I used to work with her, she got it, and we tried to integrate a process. We tried to develop a system where there was like this seamless transition between she's a spine orthotherapist and I'm a pelvic floor therapist. And it was just that there was so many things going on that our management couldn't they couldn't support a program like that because we had to deal with what was directly in front of us, which was decreasing reimbursement, which meant we couldn't have any gaps in our schedule because we had to keep the lights on. Not we, they, I wasn't upper management. I was a clinician. I wasn't even middle management at that point. And we were lucky enough that we still got to see patients one-on-one. We didn't have, to see 6 patients an hour or overlap. But it also meant that there was no room for trying things out because there was too much risk involved. We had to just keep going. And I think this is where a lot of clinicians and clinics struggle, is that reimbursement is decreasing. Cost of everything is going up. So what do? We see more patients. What does that leave us with? Less ability to think critically, less ability to open up new programs, less ability to kind of think outside of the box and play a little bit. As a clinician, you're practicing physical therapy, just like say you're practicing medicine. And the body is not like a machine. There are so many, you're working with a human being. So you have to have a little bit of wiggle room because physical therapy is an art and a science. You have to use both sides of your brain. And oftentimes you have to collaborate with more than one colleague on one patient because they might have several things going on that integrate, that affect each other. If you've got a patient who has poor balance but also has like a meniscal tear and they have so much pain they can't stand on one leg, well, how are you going to work on balance, right? You get that patient needs to have some orthopedic intervention in order to improve their balance. Their knee pain needs to get improved, right? That's something simple we get. What we fail to do as a profession is identify the crosshairs and the linkage of how pelvic floor impacts so many other things and vice versa. So many things impact pelvic floor. And then on top of that, orthopedic neurological conditions can impact poop pee sex function and vice versa. So what we're doing is leaving this whole category of talking about poop, pee, sex, pelvic floor, resting on the shoulders of the few people who just are good at talking about it and take it up as a profession. And they're taking all of that and the integration of how we could bring this whole profession to treat the whole patient is completely getting missed. And what we're doing is we're not serving our patients, and we're certainly not serving ourselves because we clam up when we talk about this awkwardness. I don't know why God gave me the ability to be able to talk about these things, but he did. And you're good at what you do, and I appreciate that. And I'm good at what I do, and I can appreciate that as well. And what I think we need to do is have more conversations about where the connection is, not the division of the body and the segments and the sections and the types of physical therapy. Where is that seamless transition from one to the next to the next? Because the body is connected as a whole. The human being works as a whole. So if we continue to delineate everything, we're just never going to get it. And then on top of that, we've got reimbursement going down, the cost of everything going up. So we're having less wiggle room to find that space. This is one of the reasons why I'm 100% supportive of the cash model, is because you're putting the decision-making process in the hands of the clinician and providing them with the ability to collaborate with the client, to collaborate and integrate with other clinicians and other people and bring people in to bring that kind of complete circle or cycle of care, which is ideally what we all want, right? We want to be able to have that connection within ourselves and then with the services that we provide. So coming back to the number one mistake that I made is that I failed to contribute my part in this whole thing of the people who were even asking me, what should I ask? What should I do? I wasn't doing it. And then from there, the rest of the people who would kind of like look at me like, what do you do when you go in that room? I don't really want to know, but I'm kind of curious. And I have a patient that I think I should send to you, but I don't know. And there's all these ways that I just fell short because I was caught up in the rat race. I was up to my eyeballs just trying to keep my nose above water because the people who were coming to me, it was so overwhelming. I had so many clients. I had 100 active clients. I couldn't even take a breath. I couldn't think. And I wasn't really serving anyone in the end, if that makes sense at all, because I was tripping, I was falling forward over each patient that I saw. And I wasn't stopping to think. And then I also wasn't tapping into the sort of creative side, but also the side that had an obligation to serve my profession, to serve others, to serve my colleagues, in that I didn't educate them on knowing what they didn't know, enlightening them on the fact that what I was doing was not so dissimilar from what they were doing, that I was using a lot of techniques that they were using, and then, I have to sneeze. I hate when that happens. And then transitioning my piece in. And I always had this dream that spine or ortho and pelvic would just marry and have this beautiful little clinical love child of collaborating treatment, incorporating some pelvic floor screening tools and exercises into core work, into balance work, into athletic performance, into return to function, into ADLs. I mean, there are so many ways in which talking about pelvic floor and talking about poop, pee, and sex are just, they're getting missed, right? Just like totally off the mark sometimes because people don't know what they don't know. So this is why I created the ebook. This is why I am doing what I'm doing. This is why I created the PPS toolkit, because I want to empower my fellow clinicians. I want to make my profession stronger. I want people to feel more comfortable talking about pelvic floor, talking about poop, pee, and sex without clamming up, and feeling confident that they know what to do with what's on the other end of the questions that they ask. A lot of people now are starting to become a little bit more comfortable with asking the questions, but then because we want to know everything, and if we don't know what to do with what's on the other end, what happens if they say this, or what happens if they come back and they give me this big long answer full of things I've never heard of? Then I'm going to look stupid. That's not empowering you. That's not educating you. So the questions were developed and the toolkit was developed as a method to kind of give you the ability to talk about these things, screen, do some key simple treatments, and then refer if need be. I don't think every single person needs pelvic floor physical therapy. And honestly, I think that a lot of people who have pelvic floor dysfunction could benefit from overall strengthening programs. There are 11 level 1A. You guys, it's so early for me. I'm still thinking. My brain's still waking up. Research articles, so highest level of evidence to indicate that pelvic floor muscle training improves stress urinary incontinence and pelvic organ prolapse. In those treatment protocols, they don't always get an internal assessment and an internal treatment. And Carrie Bowe, the kind of one of the front runners of all of this, she's led most of those research articles, and I had the pleasure of meeting her last year or 2 years ago. she has a lot of exercise videos and educational programs that aren't internal, that are helping lots of people. So if we can help people with the least invasive way, why wouldn't we? And that's where I see the rest of the profession sort of being able to find their place in this, is that they can do exercises that cue the pelvic floor. Thinking about core work as the pelvic floor never gets missed when talking about the core. Being able to do a simple screen of what those muscles can and can't do based on patient self-assessment. So I appreciate that I understand what I was doing wrong, because now I feel like I have the ability to do something about it. And I would love to help those people who don't know what they don't know, because that's the best place to start, is starting with an open mind. I'm not going to try and convince the people who don't think they need any type of pelvic floor. That's not my job. That's fine. The people who want to know more and don't know what they don't know, that's the people I want to work with right now, because your brain has already been starting to think about the questions that you might have that might come up. So you're going to fill in the blanks with what I might still be missing, because I don't know what you don't know. Only through a conversation can you find out what you don't know and ask me, and then maybe I can answer or help you find the answer. And any of my previous colleagues, I invite you to comment on this, and you can tell me what you think. But I do think that that was the number one mistake I made, was not talking about what I did and not educating fellow colleagues, fellow clinicians, my entire profession, and the public, what it is that I do. Because going into a room and everyone's saying, oh, we don't want to know what you're doing. My boss would say that all the time. I don't really want to know what you're doing in there. You're asking for more lube. Okay. So I failed to educate people. And that's where the clamming up comes from, is just a lack of education. So I'm going to pick up my game, you guys. I hope that you feel comfortable with where to start with getting the ebook, the free ebook, CompletePhysicalTherapist.com. Looking into the toolkit, deciding if that's something that you would like to maybe incorporate into your process to start to bridge the gap, and then feeling comfortable with when to refer on, which is anytime you ask a question or attempt to do a treatment plan and it doesn't work out well, it goes in the opposite direction, that's when you refer on. Okay. I tried something and we didn't get the response we wanted. Okay, refer on. All right. I would love for people to let me know what they're thinking, where they're at in this process. Are you at the point where you're ready to start asking questions? Are you ready to start screening? Are you ready to start referring? Do you just have more questions now? You can be anywhere on that scale. All right. I just would love to know where you're at so that I can do my job better. All right, I'm gonna go for my run. This is only meant to be a 5-minute post, you guys. I got on my shoebox. I'm gonna go take care of my puppy with her ear infection. And I wanna serve you guys more. So let me know what questions you have, what I can do to help you in this process so that you don't feel like you're the person who doesn't know what you don't know. You know that you know some things, and you know that you maybe want to know more. That's where I'd love for you to be at. All right, have a happy, happy, happy Friday. Stay warm if you live anywhere on the eastern side of the United States, because it's been cold from Michigan down to Florida, East Coast, Midwest. Stay warm, you guys, and I'll talk to you soon.